Now, seminoma. The microscopic appearance of the seminoma is characterized by the sheet of neoplastic cells with abundant cytoplasm, round hyperchromatic nuclei and prominent nucleoli. The prominent lymphocytic infiltrate is common, such that it is sometimes confused with the lymphoma until the surface immunophenotype has been determined, and the most seminoma do not produce serum tumor markers, but the presence of syncytotrophoblastic giant cells in a minority of the cases accounts for modest elevation of the serum HCG, human chorionic gonadotropin. Seminoma never produce alpha fetoprotein. So this is important. Seminoma never produce alpha fetoprotein, and patients whose tumor have histological appearance of seminoma and whose serum AFP is elevated should be considered to have a mixed NSGCT. So if the patient's serum tumor markers they have AFP elevated, then that should be considered who have histological appearance of seminoma. So histology is seminoma but serum tumor markers AFP is elevated, then that should be considered as mixed NSGCT, even if non-seminomatous histological pattern cannot be identified. Exception are the cases in which there is another explanation for the elevated AFP, such as if patient is having some liver disease or chronic non-specific elevation, then previously if it was elevated, then it could be considered pure seminoma. So IHC is usually positive for PLAP, that is placental alkaline phosphatase, and negative for CD30 AFP and epithelial membrane antigen EMA. So positive for PLAP, placental alkaline phosphatase, negative for CD30 AFP and epithelial membrane antigen, either negative or weakly or focally positive for cytokeratin. Histological variation of seminoma such as anaplastic or atypical seminoma, they are of no known clinical relevance, and the previous entity of spermatocytic seminoma, which is now referred to as the spermatocytic tumor by WHO pathological classification system, has different natural history and even if of uncertain relation to the germ cell tumor. So spermatocytic tumors usually occur in older individuals and they have a low metastatic potential. Orchiectomy is the only treatment for spermatocytic tumor. Unlike other germ cell tumors, spermatocytic tumors are not associated with GCNIS. So previously spermatocytic seminoma was referred to as the one of the form of seminoma, but now it is termed as spermatocytic tumor, which is a separate entity. And these spermatocytic tumors, they occur in older individuals. They have a very low malignant potential. Only treatment is radical orchidectomy. That is the only management needed, and it is not associated with GCNIS. Germ cell neoplasm in situ is not associated with it. So now non-seminomatous histologies. Germ cell tumors may be composed of a single histology or multiple histological patterns. Through though poorly understood process of mutation, epigenetic modification, differentiation, a single clone beginning as GCNIS, so starting as a GCNIS, develop into a undifferentiated neoplasm like seminoma, then primitive zygotic neoplasm, embryonal carcinoma, and further differentiation from embryonal into results in somatically different histology, different somatically differentiated tumor like teratoma, then extra embryonal differentiated tumors like yolk-sac tumor, choriocarcinoma, and non-seminomatous histologies are found in 55% of the germ cell tumor, and male germ cell tumor that contain any histological cell types other than seminomas and cytotrophoblast collectively refers to as the NSGCT. So first we will see embryonal carcinoma. Embryonal carcinoma is the most undifferentiated type of germ cell tumor and is thought to be pluripotent. Germ cells are characterized by indistinct border and scant cytoplasm. Which has been arranged in a solid sheet or in a glandular tubular structure. On IHC staining embryonal carcinoma, they positive for the cytokeratin. We saw that in seminoma it is faintly positive for cytokeratin. For in embryonal it is positive for cytokeratin, CD30, PLAP, AFP, HCG. So seminoma was only positive for PLAP, and negative for CD30, AFP, and EMA, but embryonal is positive for cytokeratin as well as CD30, PLAP, AFP, and HCG. And modest elevation of the serum AFP. There is also a serum AFP is modestly elevated, and HCG. That can be seen, and frequently embryonal carcinoma is a marker negative. Frequently embryonal carcinoma is marker negative. Lactate dehydrogenase concentration in serum is important prognostic factor in metastatic embryonal carcinoma that is marker negative. So when that embryonal carcinoma which is marker negative, LDH is LDH concentration used as an important prognostic marker for metastatic embryonal carcinoma. Now second is choriocarcinoma. Choriocarcinoma is composed of both cytotrophoblast and syncytotrophoblast. Cells strongly express HCG. So there is strongly expressed HCG. The clinical presentation of the choriocarcinoma, predominant or pure choriocarcinoma tumor, often include very high serum HCG levels. Widespread hematogenous mets. This widespread hematogenous mets is there, a high level of serum HCG, and a tumor hemorrhage. There is tumor hemorrhage. So syncytotrophoblast and syncytotrophoblastic giant cells can be associated with other germ cell histology. So presence of cytotrophoblast is required for the diagnosis. Syncytotrophoblastic cells are associated with the other germ cell. So for choriocarcinoma diagnosis, cytotrophoblast is required. So both cytotrophoblast and syncytotrophoblast with expression of the HCG. And there is widespread hematogenous mets and tumor hemorrhage. So yolk-sac tumor. Yolk-sac tumor is endodermal sinus tumor, is commonly seen in component of a mixed NSGCT, and pure yolk-sac tumor represent a significant proportion of mediastinal GCT, but are rarely seen in adult testicular cancer. Histological pattern include papillary, solid, glandular, hepatoid, macrocystic and microcystic type. Perivascular arrangement of the epithelial cells can be seen in yolk-sac tumor and are known as glomeruloids or Chival-Duval bodies. Yes, this is important. Chival-Duval bodies. IHC staining is diffuse positive for AFP and may also be positive for cytokeratin, SALL4, Glypican-3, PLAP, CD117, and yolk-sac tumor associated with a high serum level of AFP. Choriocarcinoma, high serum level of HCG. Yolk-sac tumor, high serum level of the AFP. Embryonal carcinoma, sometimes they are marker negative, and LDH is a prognostic factor. Teratoma is arise from a pluripotent malignant precursor like embryonal carcinoma, yolk-sac tumor, and contains somatic cells from at least two germ cell layers like ectoderm, endoderm, mesoderm. Teratoma commonly seen in component of the adult mixed NSGCT, and a small percentage, 2 to 3% post-pubertal male germ cell tumor appear to have a teratoma as the only histological type, but this are always assumed to harbor a minor component of the pluripotent NSGCT and are treated the same as mixed NSGCT. Immature teratoma show a partial somatic differentiation, whereas mature teratoma has terminally differentiated tissue. They such as cartilage, skeletal muscle, nerve tissue, and frequently form cystic structures. And although these cells can resemble normal tissue, teratoma of low-grade malignancy, and if untreated, grows until it is unresectable. And moreover, teratoma can give rise to secondary somatic malignancies such as rhabdomyosarcoma, polydifferentiated carcinoma, and primitive neuroectodermal tumors. And this typically display the biology of the de novo counterparts and are treated accordingly. Teratoma does not produce elevated serum AFP or HCG. In patients with elevated serum AFP, HCG should be assumed to have a non-teratoma germ cell tumor component unless the elevation can be otherwise explained.